Thank you for kind introductions. Good afternoon, ladies and gentlemen. I am Chih-Hsin from National Cheng University Hospital from Taiwan. It's my great pleasure to join a wonderful congress and discuss with you about the topic of the pulmonary hypertension in patients for heart transplant or LVAD. In the beginning, I will share a story of Mr. Lin with you. Mr. Lin is a 15 years male. He is CAD post-CABG. Ischemia cardiomyopathy with severe heart failure. Here, left ventricular ejection fraction is only 15%. Right ventricular ejection fraction is 43%. He suffered from refractory symptoms and admission for inotrophic support. According to the heart failure staging, Mr. Lin belongs to the stage D, and the heart transplant should be considered. So pre-transplant evaluation was done, including the right heart considerations. His hemodynamic data shows the mean PA was 39, his pulmonary hypertension, and the weight is 29. The diabetic venous pressure is post-capillary pulmonary hypertension, and the PVR is 2 units. Is suspected isolated post-capillary pulmonary hypertension. Actually, this is not a rare situation. In reduced EF heart failure, the prevalence of pulmonary hypertension assessed by right heart catheter was reported to be between 40 to 75. Actually, the pulmonary hypertension with the association with the right heart disease is belong to group 2 pulmonary hypertension. Here is the most common pulmonary hypertension classifications. The hemodynamic definition of the pulmonary hypertension is mean PAP greater than 20 mmHg. And the group 2 pulmonary hypertension is with pulmonary pressures. His weight is greater than 15 mmHg. So the pulmonary pressure induces the pulmonary hypertension. In isolated post-capillary pulmonary hypertension, the elevation of which lead to a proportional increase of the mean PAP, maintain a normal transpulmonary pressure gradients less than 12, and the low pulmonary vascular resistance less than 2. So according to the etiology, the management of the group 2 pulmonary hypertension focuses on treatment of right heart disease and the lowering of the left side filling pressures. The optimal treatment of the underlying heart disease, including the medical treatment, optimal volume status, and the intervention therapy, just like CRT, ICD, LVAD, and mitral clip. This therapy usually have to lower the left side filling pressure than lower the pulmonary pressures. So we give Mr. Lin the dobutamine to increase the contractility. We give the LASIS to reduce the free overload. We give the IABP to increase cardiac output, and put Mr. Lin into the heart transplant waiting list. After transplant, his PA is mean PA is 24, and the PVR was 1.71. He get a new heart without pulmonary hypertension. But not every patient belongs to isolated post-capillary pulmonary hypertension. Clinical elevation of left side filling pressure association with the neural hormone and the other mediated activation may cause excess vasoconstriction and vascular remodeling, leading to disproportionate increase of the PAP and resulting in the elevated PVG and the PVR. The left ventricular dysfunction will become right ventricular dysfunctions, and leading to severe right heart failure and higher mortality. The long-term elevation weight not only affect on pulmonary pressure, but also pulmonary vessel. How could we define the isolated post-capillary pulmonary hypertension or combined pre- and post-capillary pulmonary hypertension? I think the major difference is the pulmonary vascular resistance. If the pulmonary vascular resistance less than 2 units, is isolated post-capillary pulmonary hypertension. If the pulmonary vascular resistance greater than 2, combined pre- and post-capillary pulmonary hypertension was diagnosis. When patients undergoing heart transplant, the all-out portion pulmonary hypertension, which is a combination of pre- and post-capillary pulmonary hypertension, have increased mobility and mortality. An elevated pulmonary vascular resistance greater than 2.5 units result in nearly 30% increase in mortality with the first month post-transplant. So in our hospital, if the TBG is greater than 15 and the PVR greater than 6 units, we think it's not suitable to perform the heart transplant. If the TBG is between the 12 to 15, PVR between 4 to 6, we will see the green node and to treatment pulmonary very aggressively. The second case is Mr. Wu. He is a 51 years old male. He had dilated cardiomyopathy with the heart failure. Severe MR was also known, and the mitral valve replace was done at other hospital. But here, left ventricular ejection fraction was 17, and the right ventricular ejection fraction was only 25. He suffered from severe heart failure symptoms and frequent admission. So he was referred to our hospital for heart transplant. During the pre-transplant evaluation, the mean PA was 15.7, wedge is 34, TPG 23, and the PVR was 8.58. It's combined pre- and post-capillary pump tensions. Heart transplantation was contraindication now due to the high TPG and the PVR. We see the volume depletion is very necessary and usually association with the substantial reduction of left side filling pressure and the pulmonary artery pressure and TPG. So we give aggressive diuretics use and the optimal heart failure medication treatment. His body weight reduction from the 16.4 to 15.6. However, he suffered recurrent heart failure symptoms and admission and dobutamine use. We repeat the right heart catheter again. Now his PA is 47, wedge is 32, TPG 15, and the PVR 3.151. He improved, but not enough. We decided to put the patient into the waiting list and control his pulmonary tension more aggressively. We add on the Primacol, and 1 week later, LVAD was implantations. Several weeks later, he received heart transplantation smoothly. Both dobutamine and the Primacol have increased cardiac output and reduced wedge. But however, Primacol is a PDE3 inhibitor. He has more efficacy on lowering the pulmonary artery pressure and the pulmonary vascular resistance. The LVAD have emergence of an effective modality to improve pulmonary tension in end-stage heart failure. Several studies have highlighted substantial improvement in both mean PAP and PVR in patients supported with LVAD, allowing for successful heart transplantation in many previous unsuitable candidates with fixed pulmonary tension. The effect of LVAD support on PAP and PVR can be seen within days and sustained for several months. The post-transplant, Mr. Wu's pulmonary artery pressure was 17 and TPG 2. The pulmonary vascular resistance was 0.46. He have never had pulmonary hypertension. From this, we've seen the LVAD improve the survival and the quality of life in patients with advanced heart failure. But besides the benefit, the combined pre- and post-capillary pulmonary hypertension is a major problem in patients with the LVAD. If combined pre- and post-capillary pulmonary hypertension persists, he will worsen the RVP uncoupling and leading to right heart failure and adverse outcome, including the death after LVAD implantations. The Mr. Fang is a DCM case. He suffered from sudden collapse and VF. CPCR was performed and ECMO was implantations. The conscious was not recovered after ECMO, so TTM was performed. The patient conscious recovery after TTM, but frequent BTVF was noted. We decided to shift the ECMO to BiBAD. When we put the LVAD first, the huge RA and RV dysfunction was noted. After BiBAD support, the patient received the heart transplantation about 1 month later. Post-transplant, his PA was 43, and the cardiac output was 2.9. We used the Eno and the Primacol, and the condition improved. The PA decreased to 23, and the cardiac output is 1655. And now Mr. Fang followed at our OPD for 8 years with the good status. How about the target treatment of the pulmonary hypertension using in the group 2 pulmonary hypertensions? Endothelial antagonist, PD-5 inhibitor, or prostacyclin is good for group 2 pulmonary hypertensions. There are some exciting results about the short-term hemodynamic effect, including the sildenafil, epoprostenol, and the endothelial receptor antagonist. But almost all studies leading to a disappointing long-term result. A concern with the use of target pH drug in patients with left heart failure is that pulmonary vasodilatation and increasing pulmonary blood flow in the presence of elevated side filling pressure may potentially lead to the pulmonary edema and the cardiac decompensation. It's like when we put water into the cup filled up water, it will overflow. In our body, it will run edema. But if we put all the water in the glass first, it may be different. So for the same reason, the Group 1 pulmonary hypertension medication may benefit after volume depletion and reaching the normal weight. Recent data show the benefit about the combination of LVAD and the pulmonary hypertension medication, including the sildenafil, bosentan, mesentan, NO, and the iloprost. They all have the benefit on the significant hemodynamic improve. For pulmonary hypertension with left heart disease, the life modifications, complete management, and the optimal heart failure medication was suggested by guideline and the heart pH was symposiums. But if the RVPA uncoupling worsen and the pulmonary vascular resistance greater than 5, he was suggested refer to the pulmonary center, and the drug target to pulmonary vessel could maybe used under close monitoring. In conclusions, the all-opposing pulmonary hypertension with left heart disease is association with increasing morbidity and mortality in patients undergoing heart transplant. The strongest evidence of treatment of good 2 pH prior to heart transplant remain the use of the standard medication, heart failure therapy, and LVAD support. Several medical therapy used in the treatment of Group 1 pH have been off-label use in the treatment of Group 2 pH with varying success, but still lack enough evidence. Future research and the randomized clinical trial are necessary. This is my short talk. Thank you very much.